Caros colegas cardiologistas do Brasil, estamos aqui hoje com o professor Deepak Bhatt, do Brigham and Women's Hospital de Boston, onde nós vamos ter o privilégio de discutir com o professor Deepak sobre a aplicação da terapia com Omega-3 para a prevenção e para o tratamento das doenças cardiovasculares. O professor Deepak é um dos grandes líderes dessa área, né, autor de importantes estudos que têm demonstrado resultados muito interessantes. Well, Professor, first of all, thank you so much for being here, for joining us here in this exclusive interview for the Brazilian Society of Cardiology. It's a huge honor for me to have this opportunity to discuss with you about omega-3 therapy. You, better than anyone, you are one of the leading investigators in this field. So I'm sure we'll have a wonderful talk where we'll be able to discuss with you the results of the main studies with omega-3, some of which you have been one of the leading authors. But before we go to the studies, could you remind us a bit about how and when this whole story of omega-3 and the prevention and its application in cardiovascular disease began, and why do you believe it is so promising, Professor?
Well, first of all, thank you for having me. It's really a pleasure to be able to speak to Brazilian physicians. I've got so many friends among physicians in Brazil and colleagues and collaborators through the years. So thank you so much. As far as the omega-3 story, it really started decades ago with observations that coastal populations that live near the coast, that had diets that were high in fish, had lower rates of coronary artery disease and myocardial infarction. Those observational data span different places and times. For example, Japan, a coastal country, of course, an island country, is surrounded by water, and many of the people there eat a diet that's high in fish, not everyone, but many do, and tend to have high levels of omega-3 fatty acids, and in general have low rates of coronary artery disease and myocardial infarction, at least compared to the Western world. Now, of course, times are changing. Their diet has changed in recent years and includes a lot more fats and processed foods, but at least historically, that was true. So those epidemiologic observations led to the belief that omega-3 fatty acid intake might be associated with lower cardiovascular risk. Beyond the epidemiology, there's also lots of basic science that supports omega-3 fatty acids and their role in quieting down inflammation. Certainly at high doses, their role, at least for some omega-3 fatty acids, to lower triglyceride levels, and a variety of other biological properties. Now, the reality is that the science is much more complex than that, as is usually the case, and there are many different types of omega-3 fatty acids, and they may have differing roles in health, in cardiovascular and in other forms of health. So it's not necessarily that all omega-3 fatty acids are created equal. Indeed, they're not.
Great. Well, Professor, you, as I mentioned earlier, you were one of the leading authors of two important trials that showed some very impressive results with omega-3 therapy, the Reduce trial and the Evaporate trial. I, as an interventional cardiologist, were very amazed with the results from the Evaporate. So could you tell us a bit about these two studies and their main results?
Yes, absolutely. I was the study chair, and am the study chair of Reduce and was fortunate to also be involved with Evaporate that Dr. Matt Budoff led. And Reduce was a large cardiovascular outcome trial, over 8,000 patients, secondary and primary prevention, randomized to 4 grams a day of icosapent-ethyl, which is a prescription omega-3 fatty acid, specifically an ethyl ester of EPA or icosapentanoic acid. So a high dose of a pure prescription EPA or omega-3 fatty acid. Evaporate used the same drug, same dose, but was a mechanistic study looking at non-invasive CT angiography. both trials basically showed the same thing. That is, both these randomized trials looked at that particular drug and dose versus a placebo, and in Reduce It, we found a 25% reduction in ischemic events, even if one looked at heart events, a 20% reduction that was significant in death from cardiovascular causes, significant reductions in MI, significant reductions in stroke as well. The epidemiology for omega-3 fatty acids isn't altogether as clear about the association with stroke, but we found a significant reduction in stroke. You mentioned interventional cardiology. Just in the past couple of weeks, we published in Circulation Reduce It Revasc, where we showed a large and significant reduction in the endpoint of revascularization in this blinded trial. Emergent, urgent, elective revascularization, all were significantly reduced. The need for PCI was reduced. The need for CABG surgery in this blinded trial with independent adjudication of endpoints, even CABG was significantly reduced. We haven't actually seen these sorts of large reductions in revascularization since the 4S trial, the initial pivotal trial of statin versus placebo. Reduce It, of course, is on top of statin, so it really is an advance. And Evaporate similarly showed an early, by 9 months, reduction in various components of plaque, and by 18 months, the time of the primary endpoint, several different measures of plaque progression and plaque composition were favorably altered by icosapent versus placebo. So 2 separate randomized clinical trials, one a classic cardiovascular outcome trial, the other a mechanistic trial. Both were highly positive. Now, I should point out, though, for the sake of completeness, that these 2 large contemporary randomized clinical trials were positive, both rigorous randomized double-blind placebo-controlled trials. But there were 2 preceding trials that also were positive with the same drug, albeit at a lower dose, and specifically in Japanese patients who tend to have higher baseline levels of EPA than Western patients enrolled in Reduce It and Evaporate. And these 2 trials were JELIS and CHERRY. And JELIS was a large cardiovascular outcome trial randomized to 1.8 grams a day of icosapent ethyl, no placebo, a so-called open label trial, a probe design. So there were adjudication of endpoints that was done blindly, but there was no placebo per se, but it was randomized. And that trial produced a 19% relative risk reduction in ischemic events that was statistically significant, results that were concordant in primary and secondary prevention in JELIS, and half the patients in JELIS had normal triglycerides. In Reduce It, the majority had elevated triglycerides, about 10% had normal levels of triglycerides. So very complementary information. And CHERRY studied that same doses in JELIS, 1.8 grams a day of icosapent ethyl versus control, again, no placebo, but everybody was on a statin. Pitavastatin was the statin they used in that study. And that was an intravascular ultrasound study that showed on top of a statin versus EPA versus no EPA, or icosapent ethyl versus no icosapent ethyl, led to plaque regression by only 6 to 8 months, which if you've ever been involved in an intravascular ultrasound or IVUS study, that's pretty early. Most IVUS studies, the endpoint's 18 months or 24 months. I actually remember hearing about CHERRY and thinking, why are they looking that early? They should have picked a later endpoint, but the results were so strong and the benefits of the drug kick in so quickly that even just by 6 to 8 months, that IVUS study was positive. So you have JELIS and CHERRY, both positive with 1.8 grams of EPA in Japanese patients, randomized trials without a placebo. And then you have Reduce It and Evaporate in mostly Western patients with a larger dose of icosapent ethyl, 4 grams a day, actually 2 grams twice a day with meals, but 4 grams total per day, where those trials versus a placebo were both positive. So in fact, there are 4 separate randomized trials with the same active ingredient, icosapent ethyl, a highly purified ethyl ester of EPA, all have been resoundingly positive.
Amazing. Well, despite the positive results of all these studies that you mentioned, and the 2 that you led also, there are there's still some skepticism by some of our colleagues, mostly because there has been also some studies that fail to show a positive effect of omega-3 fatty acids. And most recently we had the strength trial presented at the virtual meeting of the American Heart Association just a couple of weeks ago. That it was also a randomized placebo-controlled trial that failed to show the benefit of the omega-3 arm. So, Professor, why and how, why these results from the strength trial differ so much from the reduced?
Great question. So there are multiple randomized clinical trials of mixtures of omega-3 fatty acids, DHA or docosahexaenoic acid, EPA, which I just discussed, icosapentaenoic acid, and other omega-3 fatty acids. And these mixtures, these trials, almost all have been resoundingly negative. There might be some subgroups or secondary endpoints that were positive in some of the trials, but overall, none of the trials achieved their primary endpoint. And this is likely because those drugs don't work. Whether they're supplements or prescription drugs, the mixtures just haven't worked. The only thing that's worked consistently has been a medium to high dose of pure EPA. And I think that's, as is always the case, the drug matters. The dose matters, the formulation matters, and the drug matters. And the most recent trials, Strength and OMAMI, were both very well done, but each used mixtures of EPA and DHA. Strength used a prescription drug, although that drug has now been terminated by the company, but it was a prescription drug. And the OMAMI trial used a dietary supplement. But in both cases, they were mixtures of DHA and EPA, 1.8 grams a day with OMAMI, 4 grams a day with Strength, so a high dose. So it's not just the dose that matters there, it's the drug, or in this case, the combination of drugs, because it's a variety of omega-3 fatty acids. So from a distance, I could understand a doctor says, oh, those fish oil drugs, most of the trials were negative. Now a couple of trials are positive. I don't believe it. There should be a class effect. But see, that's the mistake, to think there would be a class effect, because these aren't all the same drug. Yes, they're broadly speaking all omega-3 fatty acids, but they're very, very different in terms of what they're actually composed of. And if one looks at just the icosapentaethyl or the pure EPA trials, 4 out of 4 have been positive, and all have different designs, different investigators. 2 have placebo, 2 are open label, geographic diversity, 2 are in Japan, 2 are in the West, but the message is the same. So I think it's really the drug matters. And if you think about it, this isn't so unusual. Yes, sometimes with drugs like SGLT2 inhibitors, they all seem to work. But other drugs, GLP-1 agonists, for example, some of the trials have been very neutral. Others have shown significant reductions in cardiovascular events. Why is that? They're all GLP-1s. Maybe I shouldn't believe the trials that are positive. Of course I believe the trials that are positive, because the actual drug matters. Even if they're generally speaking in the same class, if you've studied one drug, you've studied one drug. You can't really generalize beyond that. So I think the results really make sense. And the drug studied in Strength wasn't a particularly good one. I think people that understood omega-3 fatty acids knew this already, but perhaps the people that developed the drug, well, of course the people that developed the drug and studied it didn't understand the biology so well. But there is a drug that is subject to oxidation, and if omega-3 fatty acids are oxidized before they're ingested, they're not going to have any benefit. They may even have a little bit of harm. We did see some evidence of harm in the Strength and OMAMI trials, where in Strength there was a significant increase in atrial fibrillation. In OMAMI, there was a trend, I'll say was almost significant to more atrial fibrillation. And reduce it, we also saw more atrial fibrillation. So I think, it's some things seem to be a class effect. So the omega-3 fatty acids at higher doses do seem to raise the risk of atrial fibrillation. They can raise the risk of bleeding as well. That wasn't seen in Strength, but we did see that in Reduce It. It was also noted in Jealous that there was an increase in largely minor bleeding, but still something to be aware of. So what this tells me is there's some properties that may be shared among omega-3s, but not everything, much like, GLP-1 agonists. Yeah, they all lower glucose. That's a shared property, but they don't all reduce MACE. Some do, and some have a completely neutral effect. And it's the same story with omega-3s. The dose really matters. And there's some basic science to back that up. One of my colleagues here at Brigham and Women's Hospital and Harvard Medical School, Dr. Preston Mason, a PhD basic scientist, but someone I collaborate with, has done a lot of work on X-ray crystallography of cell membrane preparation. So that's not in humans, it's an experimental model, but it shows that EPA, or eicosapentaenoic acid, stabilizes cell membranes, whereas DHA, or docosahexaenoic acid, destabilizes them. So potentially, if you're giving both together, even if the EPA were going to provide some benefit, the DHA might undo that benefit. That's not the same as saying DHA is toxic per se. I don't believe that's the case, but it could undo some of the benefit of EPA. There are other experimental models. He presented some work at AHA, the American Heart Association, in a particular model of oxidation of LDL, found that EPA prevented that oxidation, but DHA did not. And interestingly, the combination of EPA plus DHA did not. It's not that it provided the same benefit of the proportion of EPA in the mixture, it provided no protection. So EPA plus DHA equaled DHA. That is, in that experimental model, neither prevented LDL oxidation, whereas EPA substantially reduced oxidation of LDL. So I think there's some basic science, largely from his lab, and some other sources too, that show that different omega-3 fatty acids have different properties. So all that can really be said with confidence is that we know icosapentaethyl, a specific prescription version of EPA, works because 4 different randomized trials show that, and that these mixtures, whether they're prescriptions like the drug in strength, or if they are dietary supplements like used in Omega, even at high doses, they don't work and probably should be avoided because not only do they not work, they could still have some side effects like atrial fibrillation.
Well, that's very important information for our cardiologists, because we see that there's a lot of confusion with all these different types of formulations. It's good to make it clear that it's not all type of omega-3 fatty acids that will work. So Professor, in practical terms, how we should proceed with our patients today? Should we start, do we have enough data to start prescribing purified EPA in high doses to our patients, especially to those with the residual risks? We will be seeing it in the next guidelines. What is your opinion on that?
I think this is a great question. If I'm not mistaken, it's already in the Brazilian cardiology guidelines to use icosapentaethyl. So that's already in there, I believe.
Yeah.
But and it's already in the European Society of Cardiology guidelines, the European Atherosclerosis guidelines, the American Diabetes Association guidelines, the National Lipid Association guidelines. So it's already in multiple guidelines throughout the world. I think in terms of your question, yes, I think if it's available and the patient, can afford it, yes, I think if they meet the criteria of reduce it or jealous, yeah, they should be started on it. I think a challenge though in Brazil or more broadly in Latin America is it's not actually available.
It's not available.
Yeah, as of right now, we can't. Right now, the drug is approved for use in the United States, so someone could, in theory, get it from there. It's available in Canada and approved in Canada. I hope it'll be approved in Europe. The company that makes the drug has publicly announced they're filing for approval in Europe. So hopefully it'll get approved in Europe. It's already in the European guidelines, but the drug isn't available. It's a situation like in Brazil. The guidelines say but it's not yet available. But my hope is once European approval occurs, that the company will pursue approval in other regions, such as in Latin America. Certainly, it's also available in Japan. That's the other place that it does. I think it's available in the Middle East, too, in certain countries. There's approval that I believe is pending in China. So I imagine in the next couple of years that, it's going to be available in Brazil. I don't know the real time frame because that'll be up, I think, to the company. But hopefully, it'll be available sometime relatively soon. And, in the meantime, we're going to continue publishing data out of Reduce It, out of also the Evaporate study. And, by the time, hopefully it's available in Brazil, there'll be even more information about the drug and how best to use it, which patients are most likely to benefit. And in fact, there's other research going on with icosapentaethyl as well. I was hoping to get Brazil involved, but ultimately it was just challenging with COVID to get things done. But in Argentina, we're doing a large study of icosapent-ethyl, as a matter of fact, versus placebo in healthcare workers, or I should say in essential workers. It also includes non-healthcare workers, but people that are essential workers that are potentially exposed to COVID. So we're doing a large study there, and maybe it'll work for COVID or not, I don't know. But one thing that we're studying there, in addition to seeing if it has any effect with respect to COVID-related issues, is we're studying a loading dose. So in Reduce It, we studied 4 grams a day. In fact, 2 grams twice a day with meals is how it was given in the trial. But what we're studying in Argentina is a loading dose of 8 grams a day for 3 days, so twice the current dose for 3 days, to see how safe and well tolerated it is in 2,000 patients. 1,000 will get the drug, 1,000 will get placebo. So if that ends up being safe and well tolerated, irrespective of the COVID part of the study, that could open the door to doing trials of loading dose in ACS, in patients undergoing PCI, in patients with an acute stroke, in patients undergoing CABG, a variety of acute settings. And perhaps that will open the door for even more expanded use early in hospital initiation. So we'll see. I mean, so really my point is that while Reduce It, I think, is a practice-changing trial, there's a lot of other research that's going on that will inform us in terms of how best to use the drug in what situations. So my hope is by the time the drug is approved in Brazil, we'll have lots more information that can be useful to physicians.
That's great. That's great. Well, Professor Deepak, one last question. In your editorial to the JAG, you mentioned a revolution in the omega-3 fatty acid research. So as you already mentioned a bit about its utilization in COVID, but besides its potential for reducing atherosclerotic events, as we have been seeing with this, with the Reduce It, the Evaporate, and Jelly, do you believe there is any other potential role for omega-3 therapy, let's say for heart failure, maybe atrial fibrillation, or even other degenerative diseases such as Alzheimer's dementia, chronic kidney diseases, or maybe any infectious disease? What do you see? What's the next step?
Great question. And I know we don't have much time, so let me just say for your readers that are really interested in that, we just published last month in the European Heart Journal an article reviewing all potential future uses of icosapent-ethyl. A number of the co-authors are principal investigators of studies looking in cancer, looking in infectious disease, looking in dementia and depression. So there's a lot of research going on now. In fairness, these are mostly rather small or medium-sized trials, not reduced-sized trials powered for clinical endpoints. But if this initial series of trials show any promise in any of those disease states, cancer, infection, depression, dementia, well then, hopefully there'll be larger trials to really confirm any positive signals. So there's really a lot of research going on with the drug. I will point out, though, that editorial that I wrote actually wasn't about a drug, it was about diet and getting omega-3 fatty acids via diet. So maybe that's the final point I'll make. I mean, you mentioned, what should physicians in Brazil do? Well, I think once icosapent-ethyl is available, they should prescribe it to patients, that fit the Reduce It inclusion criteria that don't have contraindications. But I think up until that time, what can patients or healthy people do? I would suggest a healthy diet, including a diet that's high in omega-3 fatty acids. So that editorial specifically was referring to things like ALA, which is yet another omega-3 fatty acid. It's an omega-3 fatty acid, unlike EPA, that can be derived from vegetarian or vegan sources. EPA, for the most part, if you want a high dose, really fish is about the only way to get it. But if you're a vegetarian or vegan or just don't like fish, well, then a natural way would be to eat foods that are high in ALA, which is an omega-3 fatty acid that ultimately, through multiple enzymatic steps, is converted to EPA. It's not an efficient conversion in humans, but still some percentage is converted to EPA, and ALA itself might have therapeutic value. And foods that are high in ALA are ones like walnuts, which multiple epidemiologic studies have shown are associated with lower cardiovascular risk. Other things that are high in ALA, flax seeds, chia seeds, green leafy vegetables, they're not particularly high in ALA, but there is ALA in them, especially certain ones. So the things that epidemiologic studies, the foods that they've already shown are associated with lower cardiovascular risk, also happen to be high in natural omega-3 fatty acids from plant sources and not from marine sources, fish. So I think I would recommend to people who really believe in this omega-3 hypothesis, and at this point in time, I think it's more than a hypothesis, other than prescription icosapentaethyl, the only other really good option is diet, which is always a good option. But again, everything should be in moderation. That is, I wouldn't say, go eat, 1,000 walnuts a day. Of course, that, would be silly. But assuming, walnuts are part of a daily balanced diet, along with green leafy vegetables and fresh fruit and whole grains, to me, that seems like a really good way to get more omega-3 fatty acids than the typical person gets.
Well, Professor, this was outstanding. Once again, thank you so much for your time. I'm sure that our colleagues from Brazil will much appreciate our discussion here. And I know this is a topic that has been raising a lot of interest here as well. And we hope that very soon we will be able to prescribe purified EPA for our patients here. So we can see in our community that it's being a topic that is being discussed even more and more lately. And it was outstanding. So thank you so much. Appreciate it.
Yes, thank you. Take care. All the best.
Take care. Bye-bye.